In my presentation, I talked about the role of blood pressure control in patients with atrial fibrillation and also the role of kidney and renal function in atrial fibrillation. So maybe the two important take-home messages. The first one are related to blood pressure control. We know that hypertension and elevated blood pressure is the most important risk factor for stroke, both strokes, ischemic stroke and hemorrhagic stroke. Atrial fibrillation is very often a consequence of high blood pressure, so that's one important connection. And the other one is if you have a patient with hypertension and atrial fibrillation, the risk for stroke is even increased. So you have to control blood pressure even more so to protect the patients from stroke, both ischemic and hemorrhagic. But there's another issue here, because to protect the patients with atrial fibrillation from stroke, we have to anticoagulate the patients. So you use blood thinners, so to speak, to protect from thromboembolic stroke. When you do anticoagulate the patients, the risk for bleeding is increased, also in the brain, hemorrhagic stroke. So you see this scenario, the connection between blood pressure, atrial fibrillation, stroke risk, particular bleeding risk. In those patients we have to treat with anticoagulants. So the take-home message is for this, blood pressure measurement is very important. Blood pressure monitoring also out of office, so at the GP levels, outside the office, home blood pressure measurement potentially, with using also automatic devices, oscillometric devices, and repeated measurements 3 times to measure and average the blood pressure is very important to reduce the risk of stroke and bleeding in this patient. Second part is the kidney. You would think about why I should talk about the kidney or in patients with atrial fibrillation. Very important, because very often patients, like 30% of the patients, they have impaired renal function, chronic kidney disease, and those patients are even further, the risk will be further increased. So atrial fibrillation and hypertension and chronic kidney disease, the risk for cardiovascular events, mortality is even increased, but also for bleeding. And there's another note, just recent data, and I'm doing also research on this, that the type of anticoagulation we use might affect in a different way kidney or kidney function. Because the old treatment for oral anticoagulation was the use of vitamin K antagonist, but it seems that they are bad for the kidney because they promote vascular injury, and vascular injury will also promote decline in renal function, because renal function depends on vascular function. Because use of vitamin K antagonist will lead to acceleration of vascular calcification, vascular injury, and thereby accelerate the decline in renal function. While the use of the other novel oral anticoagulants we have now, or direct oral anticoagulants, NOACs or DOACs, they don't do that. They don't, cause vascular calcification. They are not harmful for the vasculature and not harmful for the kidney. They may be even protective. There are some experimental data that they're not only not harmful, but they may actively be protect against vascular calcification. So we did some studies, but also five years ago, the first studies indicated that those patients that were treated with the NOAC, particularly factor Xa inhibitors, had lower risk for renal function decline, like acute kidney injury, doubling of serum creatinine, or even the development of end-stage kidney disease. So basically, kidney is also important in those patients with atrial fibrillation and hypertension. We should monitor kidney function. If we have patients with chronic kidney disease, they are at even higher risk. So we should intensify our care. And if you think about the differential use of our oral anticoagulants, actually to protect the kidney, it's another argument for using a NOAC rather than the old vitamin K antagonist. So these are the two different parts I addressed in my presentation: blood pressure control in patients with hypertension, atrial fibrillation, but also the additional role of the kidney in patients with chronic kidney disease. I think the major challenge is to implement the knowledge we have into clinical practice. We have still knowledge gaps. So, and the future issues we have to address in research, clinical research particularly, but we know a lot because we have very good drugs, we know the treatment strategies, we have solid evidence how to treat and to which extent and what are the targets for treatment, but the control rate and also the awareness is still low or kind of in a plateau phase, and we should, promote the implementation of what we know, and therefore the interaction with general practitioners is very important, I think. Key point is just measuring in an appropriate way blood pressure, and the question of time, office time, because the office visits, in Portugal, in Germany, are very short, but maybe 1/5 of the office visits are dedicated to hypertension, because it's so prevalent and so frequent. So we have to do that, but we have to invest some time and maybe even ask for fight, and there are different national differences for reimbursement for care of these patients, just doing a proper blood pressure measurement with the novel devices, and because there's also the quality of blood pressure measurements can be improved. The other thing is prevention, looking into the young. The children, the adolescents, obesity, nutrition, physical activity, which is also a challenge now we learned during the COVID-19, physical activity goes down, sports in school, unhealthy diets, etc. And so we are part of the cardiovascular prevention agenda we have, fighting cardiovascular disease in adulthood. Also starts with education already and implementation also in early life. Maybe education in school programs is very important also.